Neuropathology, so we're doing CVAs, both varieties. We have the hemorrhagic and the ischemic types, right? And I can't, it looks like I have dysarthria right now, or I can't read that at all. Anyways, we have different types of strokes, ischemic and hemorrhagic. We'll spend a lot of time with ischemic, but it has the same symptoms as hemorrhagic, right? There's an interruption of blood supply to the brain. So we'll spend a lot of time with the vessels and the different symptoms that can occur with strokes, and then we'll kind of we'll intersperse, we'll do a lot of hemorrhages in there. There's a lot of intraparenchymal hemorrhages, intraventricular hemorrhages, subarachnoid hemorrhages, subdural hemorrhages, epidural hematomas. There's a lot of things that can be hemorrhagic in the brain that we'll be touching on. And then we'll be finishing off with traumatic brain injuries. So there's a lot of different interspersed hemorrhages in there as well. Not all TBIs have hemorrhages, just like a concussion is a TBI technically, right? But there are, epidural hematoma, subdural hematoma technically are TBIs, right? So we'll be talking about these for neurological pathology. All right, so ischemic strokes and hemorrhagic strokes. All right, so ischemic strokes are definitely much more common. About 87% of our strokes are ischemic, and hemorrhagic strokes, the other 13%, and they're much, much more deadly. And it's a concern that we have to then fix, hopefully identify people that are at risk that could develop an aneurysm, for instance, like hypertension puts you at risk for aneurysms. Hypertension puts you at risk for it just busts through the artery and bleeds into the brain, right? And we can pick that up on a CT scan. And on a CT scan, it's going to be what color? It's going to be a white color, right? So you're going to have to see that bleed on CT scan, and that's not good because it has a higher mortality. And also, when someone has a stroke symptom, they, hopefully we can get them medication to reverse a stroke, right? So if they have a bleed of any sort on the CT scan, that's off the table. We can't give any more thrombolytics to break up a clot that usually causes ischemic strokes, right? Ischemic strokes are usually dark gray on CT scan, but we don't want to see that because it takes 12 to 18 hours for ischemia to show up on CT scan in the first place. So really want a clean CT scan before you give any kind of thrombolytics, right? So we'll talk about the different territories of the brain as well, right? The PCA territory is a vessel, MCA territory is a vessel that feeds this part of the brain, ACA territory feeds the front half of the brain. So we're going to be looking at those different territories and the symptoms that might develop from there. So we talked about a lot about cranial nerves. So cranial nerves will make their, turn their ugly head again. And also we talked about a few different pathologies that might happen, like laterality we've talked about before, right? If it happens on the right side, insult or lesion on the right side, you're going to usually have a deficit on the left side, right? So this left-sided, I think looks like right-sided facial droop. You got right-sided facial droop. That means I have what kind of stroke on what side of the brain? I got a left-sided stroke, right? And then we talk about cranial nerves. They don't decussate. They don't have they're ipsilateral. They have the same side. So usually you look towards the lesion when they have a stroke. And that's usually like your PCA strokes will have that characteristic. Okay. We mentioned decompressive craniectomies when we talked about increasing ICPs. And obviously, you have a bleed in the brain, that's going to be much higher risk of increasing ICPs. You definitely have a lot of ICP elevation when you have an increasing blood mass inside the body, or inside the brain, I should say. Right? So we'll be talking spend a lot of time with our circle of Willis over here, all right, and the different blood supply that it gets, and it can be impaired in its flow. And of course, you can get stroke complications as well when you have a stroke, right? They don't just all bounce back. There are some that will just bounce back within 24 hours. We don't call them technically, they've been trying to weasel it out of stroke definitions, but that's just a TIA, a transient ischemic attack, where the stroke symptoms go away within 24 hours, right? They're gone, right? But it's a indication that they're going to have an ischemic stroke or even a hemorrhagic stroke within 30 days, right? It's very, very high risk. All right, so we'll talk about ischemic stroke, a little bit about TIA. We'll talk about hemorrhagic strokes and aneurysms as well, and how to fix aneurysms and what aneurysms are all about. And they are considered a type of stroke, an interruption of blood supply, right? If I have a aneurysm and it ruptures, that's the interruption of blood supply from wherever it was going, right? Usually aneurysms are sitting right in this little area right there, and that's the circle Willis is like a huge roundabout where all the blood is being rerouted to different parts of the brain, whether it be the posterior circulation, the PCA, the middle circulation, or the middle cerebral artery, or the anterior cerebral artery and the anterior circulation, right? So we're looking at strokes today, and hopefully I don't have any kind of verbal issues or strokes.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very Darrison, but let's go to Terrace Tazen, look for the head of the pit.
All right, so she's having aphasia, right? So she's having expressive aphasia. She's unable to articulate speech, and that's a focal neurodeficit, right? So there's global neurodeficits we talked about with comatose patients when back in the normal neuroassessments, right? Where they're lethargic or drowsy. Those are just very, very generic. Whereas this is something super, super specific that's not working, right? It could be motor symptoms where they're unable to move part of the body, right? It could be a aphasia of some sort where they're unable to speak. A certain part of the brain is not working, specifically the Broca's area is not working, or the Wernicke's area, or the cortical pathways in between those are not working. Right, so that's the idea behind strokes. They are focal neurodeficits because a specific part of the brain is getting impaired because the blood supply to it is not working. All right, so a sudden focal neurodeficit. It's all of a sudden, and it's important that it's reported right away, and we have all kinds of strategies to get people to come to the hospital fast by using the FAST scale or the BFAST scale to make sure they are presenting, because strokes don't hurt. If they're a hemorrhagic stroke, it hurts, right? That's a lot of blood in the brain, that's going to hurt. But a regular stroke is like, oh, can't move my right arm. I'm going to go take a nap to see if I can, sleep it off, right? Or I'm not able to talk. I guess I must be sleepy today. I didn't get a lot of sleep last night. I drank a whole bunch of caffeine, a little meth from my friend, and I had a little cocaine right now. It must be, we'll figure it out. I'll take a little nap right now. So these are things that can cause a focal neurodeficit that is sudden onset. And we need to know when it happened, right? So that's the last known time well, because we can give certain medications if they meet criteria, right? Thrombolytics, right? It's every 40 seconds we're getting a stroke occurring, right? A lot of people are living with deficits to begin with, and it's a really huge expenditure insurance-wise and money-wise, right? So we want to make sure that it's the 5th most common cause of death in the U.S. as well. So we have a disruption in blood flow of some sort. And we'll talk about the blood flow. I promise you guys are itching to know about the circle of Willis and the posterior circulation and such. We'll talk about all the blood flow places, like the middle cerebral artery here being blocked. So we got a blockage right there. And this whole area of the brain is being blocked, right? So we're going to be losing that function. And if you remember your homunculus, spoiler, right? The homunculus is laid out across that lobe, right? So we can see some deficits because of it, right? So we can have a blockage or we can have bleeding, right? So bleeding or blockage. So bleeding is obviously much worse, right? That's a hemorrhagic stroke, and it's only 13% of your strokes, but it is the most deadly. And notice hypertension is on both of these, right? Hypertension is there, and it's also, I think, another spot too. But hypertension causes both ischemic strokes and hemorrhagic strokes. That patient that's dabbles in meth and cocaine, they're definitely probably going to burst through an artery, right? Whereas someone who has chronic hypertension, it's like I'm super clean, I'm super healthy, I haven't been to a doctor in 10 years. It's like, well, you've had hypertension for 10 years, and it's done a whole bunch of work on your kidneys and your heart, and it's then caused damage to your brain as well, right? It damages the small vessels of the brain right there. And that small vessel damage can cause a like hypertrophy of the vessels, and that can eventually lead to no flow to those small little areas of the brain. We call those lacunar strokes, right? Lacunar strokes are small vessel strokes. Diabetes kind of is the same thing, where it causes crystallization of your vessels, of your nerves, of your hemoglobin. Your hemoglobin A1C is crystallized rock candy on your hemoglobin. It does the same thing to your vessels, and they occlude to the point where there is no flow to the small vessels, right? You get little lacunar strokes in there. So back to hypertension, though, it causes lacunar strokes, ischemic strokes. It also causes hemorrhagic strokes. It can cause aneurysms to happen. It can cause just a bleed straight up into the brain itself, right? So we'll talk about hemorrhagic strokes in its own little section. The next sections will be all on strokes in general, right? And a little bit on ischemic, and then we'll switch gears to hemorrhagic strokes towards the end, right? So we got bleeding strokes and we have non-bleeding strokes or ischemic strokes. It's a blockage of blood flow to a specific area of the brain. Again, it's the most common type of stroke, 87% of our strokes. And the most common variety is a large vessel stroke. We talked about ASCVD attacking your coronaries, right? Well, your coronary arteries are about the same size as your cerebral arteries. And the same size as the penile arteries too. So erectile dysfunction or a peripheral arterial disease or a coronary artery disease or stroke, you're at risk across the board, right? Whatever you come up with, whatever you end up having is just a roll of the dice, right? It could be based on some history too, like your genetic history and such, and your activity. But basically, it's a roll of the dice which one you're going to get. So your ASCVD patients get statins, they get aspirin because they're high risk for any one of those events, right? And they need to get their diabetes under control because ASCVD is atheromas developing across destroyed vessels, right? It's like a landscape for all the fat to lay hold of, and hypertension is definitely going to make that worse, and diabetes is going to make that worse too. So we got to fix all those chronic diseases, right? So we have a thrombotic event, which just like with your coronary is a thrombotic event, all of a sudden the atheroma ruptures, exposes collagen, the platelets aggregate, they get activated, the coag gets activated, and you get a clot that forms immediately and blocks blood flow, right? So same thing that happens in the coronaries happens also in the large vessels of the brain, right? Our MCA strokes, right? So over here, MCA, where's my MCA at? I gotta think a better picture, but either way, we have a area of the brain that gets blocked, right? A little blockage of flow. It could be MCA is the most common, the middle cerebral artery. It could be the ACA artery. It could be the PCA. It could be the basilar. It could be the vertebral artery. Right? All these things can occlude off all of a sudden, right? That's why we say these are stroke events, right? All of a sudden, they cannot speak or they cannot move one specific part of their body, right? Whether it be the legs, like an ACA stroke, or the arm and face, like a PCA or MCA stroke, right? So these are thrombotic events. And like I mentioned, a TIA is a warning sign, right? A TIA is a warning sign that you are going to have an ischemic stroke in the next 30 days, right? 50% likely that you're going to have a stroke in the next 30 days, right? So if all the symptoms of that focal neurodeficit go away in less than 24 hours, then it is considered a TIA. All right, and then carotid artery disease is its own thing as well, but it's where your carotids start getting blocked off, right? So they're getting occluded, and of course your carotids are what feed the whole brain to begin with, half of your brain's blood supply. So that's also a situation that they can block off completely, or a piece of it can embolize, right? It can thrombosis, but then it also embolizes off and blocks a distal vessel, which would be our MCA, for instance, or our ACA or PCA arteries. Okay, so cardioembolic strokes. These are different types of strokes. We had our large vessel we talked about. We talked about our small vessels, our lacunar strokes, and we have cardioembolic strokes. Right, that's a clot fragment, not a fragment from like our carotids. So we kind of describe those as ischemic, because as large vessel because it's affecting a large vessel such as our carotid, right? And has like the same process of atheromas and whatnot. Now we're switching gears to something else. There's a free clot being formed somewhere in the body. It could be a DVT. It could be a atrial thrombus, a ventricular thrombus post-MI. It could be a thrombus anywhere, right? An SVC with someone with cancer, with Horner syndrome, or something weird, right? But we have something coming from somewhere, right? So that clot broke off from a clot, from a thrombus, and became an embolus, and it embolized throughout the body. We kind of summarize it in cardioembolic, but it really it could come from anywhere, right? Because it's like, well, how would a DVT get to the brain? I thought it has to go through the pulmonary arteries and then to the pulmonary capillaries and the pulmonary veins. How'd that clot like shift sizes and get small and get big again? Well, 20%, 30% of our population has a patent foramen ovale, right? Where it just goes from the venous system, whoop, and it goes right on through and gets popped up to our brain, right? So we do these echoes at bedside to do what we call little bubble studies to see if they have this foramen, they have this defect in their atria to begin with. And maybe that can explain why they have the stroke that they have, right? They literally take a 10cc syringe, not a sterile one, take a 10cc syringe, they agitate it really quick, and they give it as fast as possible so they can see it on the echo, right? And then you have patients and nurses that are like, oh, no, that bubble, don't let that bubble go in. It's like we literally give 10 cc's of bubbles, and it causes no issues. Right, because if you give like 10 cc's of air, that's a problem. Right, if you give like bubbles, like 1, 2, 3 bubbles, it's not going to be the end of the world. Okay, so yeah, you could have a clot from on the venous side, or a clot on the atria, on the arterial side. Right, so that's one of our really common dysrhythmias. Most common dysrhythmia is AFib, and AFib can then lead to a stroke. About a 20% chance of getting a stroke if you have AFib. So 1 in 5 patients have AFib get strokes. Right, so if you've seen 5 AFib patients, you just look at the telemonitor, guaranteed to see 5 patients have AFib, and they are high risk of having a stroke. I bet you 1 in 5 of them has had a stroke. Right, so these are the odds of AFib. So anytime someone gets AFib that's permanent, right, we have to then start them on what? To prevent strokes. On not DAPT, but DOACs, right? DOACs are the new warfarin. Not by new, I mean like 18 years new, right? So warfarin you've been phased out. You might have seen someone who's never seen a doctor in 20 years, but they've taken warfarin, right? There are fringe cases for warfarin, but there's most commonly they're going to be on a DOAC, a 10A inhibitor, right? For AFib. So we have AFib here. We got a cardiobolic stroke, okay? And then a dilated heart. So a huge dilated heart is going to start causing a breeding ground literally for clots to form, right? So it could be the atria that can be deformed, or it could be the ventricles that get deformed. You get a clot that will then embolize. And by the same token, when you get CHF and heart failure with reduced ejection fraction, a HFrEF, you can then get the ventricle gets bigger and bigger and bigger, or the atria gets bigger and bigger and bigger, and it starts separating out the valves, right? The valves start getting bigger and bigger as well. And that's going to then make the valves have valve disease. And now we have a risk of clots forming there too. Okay, and of course if that didn't happen, then the valves are going to start causing the chamber behind it to get dilated, and now that can get a clot in that chamber, right? So all these things are a snowball effect of developing emboli that can then make their way to the brain somehow. Right, and then just tied for first place of like atherosclerosis is unknown. I have no idea how you got a stroke. You just have a stroke. Right, 30% of the time, you have no freaking idea what happened. Right, you just have you lost half your body. Sorry, so sad, so sad. Don't know what happened. Right, we're going to reduce your risk factors. We're going to do those things afterwards, but we have to deal with what we're dealing with right now. And there are other reasons, like really, less than 10%, where you have like a physical clog in your system. It's not like a clot that's in the way, but it's a clog. Like it is very, very thick. So someone's like, I guess you could say dehydrated, but like more where there's increased cellular load, like certain cancers, and you see like a white blood cell count more than 100K, that's a red flag because they're just like, what's the problem? The guy looks fine, he's on room air. His white blood cell count's 140. Well, the problem is that can occlude those white blood cells can occlude the vessels. It makes it from like Kool-Aid to super thick syrup, right? Or high fructose corn syrup, I should say, right? So it's very, very, very thick. And also the properties of like sickle cell that can clog the brain, can clog the heart, can clog many of the lungs. These are properties that can cause a stroke-like event, right? And then we have global. Yes, they're technically strokes because if you have lack of blood supply to one area of the brain, right? And that's you could argue that if I have global low cardiac output, is that a lack of blood supply? It is, right? So there are global strokes where you have global low blood pressure, you have global hypoglycemia, you have global hypoxia, right? These technically are strokes, but we have, they have their own little deal as well that we want to make sure we avoid. We talked a lot about hypoxic ischemic encephalopathy, right, from cardiac arrest or from a drowning or something like that effect, electrocution. But these are, basically causing stroke-like symptoms, right? And we know that hypoglycemia causes, a sudden focal neurodeficit as well. And it's something we always rule out first before we say they actually have a stroke. All right. And then we'll talk about blood pressure being dropped way too quickly. We talk about hypertension with hemorrhagic bleeds. You want to bring the blood pressure down, but you don't want to bring it down too low because then you'll actually get a stroke on top of it, an ischemic stroke on top of it. All right, so we'll talk more about the watershed infarcts that can occur when you bring the blood pressure down way too quickly. Okay, so those are all types of strokes, kind of some of the causes of the strokes.